Today we have DAPANORM CONCLAVE. The topic of this conclave is time to take the lead, practical utilization of SGLT2 inhibitors. So I'll be facilitating these sessions. First, we will from 6 to 6:05. First, we will giving the opening and introduction of this panelist. Then implementation of this SGLT2 inhibitors for kidney protection. This session will be taken by Professor H.J. Lambers, Springs. From 6:25 to 6:45, the next step for SGLT2 implementation, Indian overview will be taken by Dr. Avdesh Kumar Singh. Then we will take the question answer sessions from attendees and followed by this vote of thanks. Professor Hido Jan Lambers, is a professor in clinical pharmacy and pharmacology university medical center, Goringen. Currently, he is having membership for scientific boards in Keto Guidelines Committee, Diabetic Kidney Disease, and he is a chair of FIND CKD trial and was co-chair in many trials linked like Mosaic, DAPA CKD, Align, Frontiers, and Credence. He has more than 400 scientific publications and 71 HERS index. Sir is international speaker for this conclave. For national speaker is Dr. Avdesh Kumar Singh, sir. He is MD Medicine, DM Endocrinologist, and Senior Consultant Endocrinologist, Kolkata. Currently, he is working at GD Hospital and Diabetes Institute, Kolkata, India, and he is Deputy Editor of Clinical Diabetology. He is Associate Editor at IJDC, World Journal of Diabetes, Additional Editor at Williams Endocrinology, and he has more than 130 scientific publications with national and international authors. Sir is speaker in many national and international conferences. I welcome you both of you, and I would like to hand over this session to Professor Hidojan Lambers, Springs. Over to you, sir.
Thank you very much for the introduction and for the opportunity to participate in this webinar, where I will be talking about SGLT2 inhibition and kidney protection. And my main message is that we should not wait. We have to implement these new therapies for our patients with type 2 diabetes, but even beyond, also for patients with kidney disease and heart failure. I'll be talking about the clinical benefits, and I will do that with the mechanism of action of SGLT2 inhibitors in mind. So let me share my slides and let's kick off. The topic or the title I have been given is the implementation of SGLT2 inhibition for kidney protection. My disclosures are listed here. I work with pharmaceutical companies together to identify and develop new drugs for patients with chronic kidney disease and diabetes. We know that in 2017, 480 million people around the world were diagnosed with type 2 diabetes. We also know that about 40% of these patients will develop chronic kidney disease during their life. And in fact, in 2017, 700 million people around the world were diagnosed with type 2 diabetes. There's a close interaction between the kidney and the heart, and kidney disease increases the risk of heart failure, and the reverse is also true. In 2017, 64 million people were diagnosed with heart failure, and many of these patients also had type 2 diabetes. So here we see a close vicious circle between diabetes, kidney disease, heart failure, the one disease damaging the other organ, further damaging the other organ, setting a vicious circle into play that leads to further organ damage. Fortunately, we have drugs that reduce the risk of kidney failure and heart failure, and these are the SGLT2 inhibitors. Originally developed for the treatment of type 2 diabetes, but in 2016, it became clear that these drugs are very potent drugs to reduce kidney disease progression and reduce the risk of kidney failure. Originally, for the first time, observed in the EMPA-REG outcome trial. You might remember the meeting in Stockholm, in Sweden in 2015, where the data were presented for the first time. And some people thought that this was a chance finding. But that finding, that kidney protective effect observed in EMPA-REG, was confirmed in CANVAS, DECLARE, and later on in VERTUS. So 4 clinical trials in patients with type 2 diabetes at high cardiovascular risk demonstrate the kidney protective effect. But soon after these trials, or actually also during the conduct of these trials, specific kidney outcome trials were initiated. DAPA-CKD and credence demonstrated that even in people with diabetic kidney disease, or DAPA-CKD in people without diabetes and chronic kidney disease, SGLT2 inhibitors slow the progression of kidney disease and reduce the risk of kidney failure, heart failure, and even in DAPA-CKD, these dapagliflozin prolonged survival and reduced the risk of all-cause mortality. Nowadays, we even have 4 clinical trials in patients with kidney disease that have demonstrated the benefit of SGLT2 inhibitors. Canagliflozin in credence, sotagliflozin in SCORED, dapagliflozin in DAPA-CKD, and most recently, last month, the EMPA-Kidney trial was presented and it was demonstrated that empagliflozin also protects the kidney. Now, what you can see in the bottom graph is that the DAPA-CKD and EMPA-Kidney trial enrolled patients without diabetes. 1 out of 3 in DAPA-CKD and about half of the patients in EMPA-Kidney did not have diabetes. All these trials demonstrated significant risk reductions in the order of magnitude between 30 and 40%. But interestingly, DAPA-CKD was the first trial that demonstrated the benefit of SGLT2 inhibitors in patients with and without diabetes. And we can see the 2 Kaplan-Meier curves in this graph. There is a clear benefit in both subpopulations. How is that possible? How do SGLT2 inhibitors prevent kidney disease progression and reduce the risk of kidney failure, even in people without diabetes, since it was originally developed as a diabetes drug? I believe that these drugs have very potent effects in the kidney itself. Now, I have to explain you a little bit about kidney physiology. The kidney tries to stabilize filtration under different settings of kidney perfusion. Now, suppose that in a patient with an intercurrent illness, the perfusion in the kidney is reduced. That would lead to a drop in GFR. But the kidney directly adapts in order to stabilize the GFR. The kidney is doing that by a mechanism which is so-called tubulo-glomerular feedback. If kidney perfusion is reduced, there's less sodium filtered in the glomeruli. And that leads to a reduction of sodium delivery to the macula densa, which is located here in the distal tubule. The macula densa is a sodium center. And as soon as there's less sodium delivered to the macula densa directly reacts by dilating the afferent arteriole. That leads to an increase in renal perfusion, an increase in GFR, and an increase in sodium filtration, so that there is more sodium delivered to the macula densa. So in a setting where you would expect that GFR would decrease due to a reduction in renal perfusion, the kidney adapts and stabilizes renal blood flow and GFR. Now, in a patient with type 2 diabetes or kidney disease, there's more SGLT2 transporters and there's thus more sodium and glucose reabsorption in the proximal tubule that leads to a reduction of sodium chloride delivery to the macula densa and a dilation of the afferent arteriole, just like in that patient in whom renal perfusion is reduced. Because of the dilation of the afferent arteriole, GFR increases, and that leads to glomerular hyperfiltration and a high intraglomerular pressure. And we know that glomerular hyperfiltration is the first manifestation of diabetic kidney disease and associated with high risk of microalbuminuria and a progressive kidney function loss. Now, when we treat this patient with an SGLT2 inhibitor, we block the glucose and sodium reabsorption in the proximal tubule, and that leads to an increase in sodium chloride delivery to the macula densa. That leads, in turn, to a constriction of the afferent arteriole, a drop in renal blood flow, and a drop in intraglomerular pressure and glomerular hyperfiltration. And this is what we clinically see as the reduction, the acute reduction in GFR when we initiate an SGLT2 inhibitor. So that the reduction in GFR is a hemodynamic effect and reflects the mechanism of action of an SGLT2 inhibitor. And indeed, when we look at the clinical trials with SGLT2 inhibitors, and this is just one example, you can see that during the first weeks of treatment, there's an acute reduction in GFR of about 4 mils per minute, followed by a nearly complete stabilization of the long-term GFR trajectory. And this reflects the kidney protective effect, whereas this initial dip in GFR reflects the reduction in glomerular hyperfiltration, but does not reflect kidney injury or damage. SGLT2 inhibitors also reduce albuminuria. And we know that if we reduce the glomerular pressure in the glomeruli, we reduce the pressure on the filter. And that leads to less albumin leakage through the glomerular basement membrane, and thus a reduction in albuminuria, as we can see here with dapagliflozin compared to placebo. Overall, a 29% reduction in albuminuria. So what do we know with dapagliflozin? We can protect the kidney in the early stage as well as in the late stage. And this has been demonstrated. For example, with the DECLARE trial, a clinical trial in type 2 diabetes, with patients having a GFR of about 85 mils per minute, clearly demonstrating that in this early stage of diabetic kidney disease, we can reduce the risk of end-stage kidney disease or a 40% GFR decline by 46%. Now, at the other hand, in patients with established nephropathy, those with a GFR below 60 or very high albuminuria, the DAPA-CKD trial demonstrated that SGLT2 inhibition reduced the risk of kidney failure or 50% GFR decline by 44%, almost a similar magnitude of effect as observed in the DECLARE trial. So we can conclude that dapagliflozin is effective across the spectrum of GFR values. Now, interestingly, if we increase the sodium delivery to the macula densa, we also increase sodium reabsorption in the distal tubule. Increased sodium reabsorption in the distal tubule requires energy, and that directly leads to an increase in EPO. And we know that when we initiate with treatment with SGLT2 inhibitors, we see a transient increase in EPO levels, and that leads to an increase in hematocrit. And these are new data from the DAPA-CKD trial just published last month at the American Society of Nephrology, indeed demonstrating that we see increases in hematocrit, probably secondary to increases in EPO during treatment with dapagliflozin, both in patients with anemia at baseline as well as in patients without anemia at baseline. In addition, in the DAPA-CKD trial, we demonstrated that dapagliflozin reduced the risk of anemia in people without anemia at baseline. You can see that here a 47% relative risk reduction for the development of anemia. And this effect is similar in patients with and without type 2 diabetes. Among patients with anemia at baseline, dapagliflozin corrected anemia. So these patients were less likely during the trial to have anemia. And that's why you can see here there is more correction, more likely, if you were assigned to dapagliflozin, you were more likely to have a correction of anemia as shown here. And again, similar effect sizes in patients without and with type 2 diabetes. Now, by delivering more sodium to the distal tubule, we also enhance the electronegative charge in the distal tubule. And that leads directly to an increase of potassium excretion via the principal cells in the collecting cortical duct. By increasing the excretion of potassium, we actually modestly decrease serum potassium and we decrease the risk of development of hyperkalemia. And this was indeed seen and first demonstrated in the Credence trial in patients with diabetic kidney disease. Over time, we see less hyperkalemia or the initiation of a potassium binder. And on the right here, we look at the effect of initiation of a potassium binder, which less often occurred in the canagliflozin group. So SGLT2 inhibition reduces the risk of hyperkalemia. And this is also demonstrated in a meta-analysis published earlier this year in Credence. If we look at all the clinical trials, whether these are patients with type 2 diabetes and established cardiovascular disease, there's a risk reduction for hyperkalemia. There's a risk reduction for hyperkalemia in patients with diabetic kidney disease in Credence, as well as in patients with heart failure. And that's also shown in the Soloist trial. So a very consistent effect of SGLT2 inhibitors, which is clinically important because hyperkalemia can limit the use of ACE inhibitors or angiotensin receptor blockers in patients with chronic kidney disease. But if we treat these patients with an SGLT2 inhibitor, we can perhaps prolong the use of the ACE inhibitor angiotensin receptor blocker. I would also like to tell you a little bit more about hospital admissions in patients with chronic kidney disease. And again, these are new data from the DAPA-CKD trial published last week in the Annals of Internal Medicine. What we found in DAPA-CKD is that among patients who were receiving placebo, 1 out of 3 approximately were hospitalized during the trial. And these are unplanned hospitalizations. And I think that's a lot. During only 2.4 years, 1 out of 3 patients with chronic kidney disease will be hospitalized. That proportion is reduced to 1 out of 4, 25% with dapagliflozin. A statistical significant risk reduction of 16% as shown here in the Kaplan-Meier curve. Some patients had more than 1 hospitalization during the trial. And when we look at all hospitalizations, so the first and the subsequent, there's a 21% risk reduction for this event. These data from DAPA-CKD, from Credence, as well as from EMPA-Kidney and SCORED have changed the guidelines. The new American Diabetes Association guideline now recommends the use of SGLT2 inhibitors in patients with chronic kidney disease because of their proven efficacy. If glycemic control is not achieved, the guideline recommends to add a GLP-1 receptor agonist because GLP-1 receptor agonists are powerful drugs to reduce A1C, but in addition have also been shown to confer cardiovascular protection. So here we see that in a little bit more detail. The new KDIGO guideline, the title still says 2020, but it's now the 2022 guideline, recommends SGLT2 inhibitors as well. And the guideline recommends to initiate an SGLT2 inhibitor in all patients with a GFR above 20. And that threshold is based on the EMPA-Kidney trial because EMPA-Kidney enrolled patients with a GFR above 20. You don't have to stop an SGLT2 inhibitor if the GFR drops below 20. Please continue. In the clinical trials, SGLT2 inhibitors were continued even when the GFR dropped below 20. These new guidelines, they state that they suggest that we now have very powerful drugs, and the data has shown that we have very powerful drugs to protect the kidney. That means that we have to start identifying patients with chronic kidney disease. And according to the ADA guideline, we have to monitor GFR and albuminuria at least once a year in patients with type 2 diabetes. Now, when we look in clinical practice, and these are, for example, data from the United States in 1 million people with type 2 diabetes, and every circle in the graph is a hospital. And these hospitals are located in different clinical care settings. And what we see is that overall, on the left, the majority of the hospitals measure GFR every year in all patients. It's about 90%. But when we look on the right, when we look at the monitoring of albuminuria in these hospitals, in these patients with type 2 diabetes, it's about 50% on average. So about 50% of patients will have an annual albuminuria measurement and the others don't. And this indicates that there is still room for improvement, that we can do much better in terms of monitoring for albuminuria. And that's so important because albuminuria is a strong renal and cardiovascular risk marker, which tells us which patient is at high risk for dialysis or kidney transplantation. And then when we find these patients, we have to start using effective drugs like SGLT2 inhibitors. But when we look over time, although we see an uptake over time in the use of SGLT2 inhibitors, there's still relatively low usage. In the United States, the dark blue line in 2019 only used by 12% of patients. And when we look at these patients, it's particularly clear that in the United States, the Asian and the Black people are not treated as often as people, white people, or Latin people. So again, demonstrating room for improvement with respect to the treatment of chronic kidney disease. So I've shown you that SGLT2 inhibitors slow progression of chronic kidney disease and reduce the risk of kidney and heart failure in patients with type 2 diabetes, chronic kidney disease, as well as in patients with heart failure. The benefit of SGLT2 inhibitors is present, and that benefit is regardless of diabetes status, kidney function, and even in patients with without cardiovascular disease or heart failure, the drugs are still protective. I've also shown you that SGLT2 inhibition has favorable effects on many complications of kidney disease. I mentioned anemia and hyperkalemia, but these drugs are also reducing blood pressure, even in people with resistant hypertension. They reduce the risk of gout, so they have many additional benefits beyond reducing the risk of kidney failure. And thus, these data highlight the need to implement these findings and the guideline recommendations in clinical practice. I thank you very much for your attention, and I look forward to any question you may have. You can submit your questions through the chat. Thank you.
Thank you, sir. So we'll take this question answer session after the another sessions. So over to you, Avdesh sir.
Thank you. I hope my slides are visible.
Yes, it's visible, sir.
Okay. So good evening, everyone. I heard we have more than 2,000 practitioner doctors listening to Professor Hidu and me at the moment. So thank you, everyone, to catch up in this Saturday evening. So my job is to take it forward from what Professor Hidu taught us, how SGLT2 is doing great when it comes to kidney and heart. So the next step is to implement the use of SGLT2 in clinical practice. I'm going to put as an Indian endocrinologist, what is our perspective in our part of work? Just to tell you my disclaimer that this is a Alkem sponsored program. Alkem is a branded generic dapagliflozin makers in India, and to my knowledge, is the first pharma company to have a FDC of dapagliflozin, sitagliptin, and metformin in this country, since they conducted a double-blind randomized controlled trial called MESIDA trial, which has shown a triple drug combination is better than a dual combination. Of course, it has to be, but then this is the first trial which has been done in India, and therefore DCGI has approved a triple drug combinations of DAPA, Sita, and metformin from the Alkem. I do have a conflict of interest with almost all innovative SGLT2 makers in India, and I've received the speakers on the video. However, this presentation has nothing to do with my duality of interest, and this is all slides made by me. Now, when it comes to Indian perspective, what we need to learn that we look to be a little different from the rest of the world when it comes to treating type 2 diabetes. Why we are different? You can see that we were the rank 1. We had a dubious distinction to become a diabetes capital of the world. At the moment, we are at number 2, just behind China. But then the projected data suggests that very soon, by 2025 or so, we would be put at rank 1 again. And therefore, we have to be a little bit concerned, and we need to, fire all cylinders while taking care of type 2 diabetes. Also, please remember that type 2 diabetes occurs a decade earlier in Indians compared to the West population. And our type 2 diabetic patient gets complicated much earlier when it comes to both cardiovascular and kidney damage compared to the Western population. Furthermore, even if we develop cardiovascular and renal disease, the extension of cardiorenal involvement are far, far aggressive in Indian type 2 diabetic compared to the Western population. And therefore, we need an effective tool to prevent such cardiorenal complication arising out of type 2 diabetes. Now, when we look back to the guidelines in the world, where from the Professor Hiddo ended, that how to implement and recommend these effective tool in clinical practice with the data we generated in past decade or so. Now, if you look back at the guidelines, and of course, when I'm talking about guideline preliminary, we are talking about ADA-ESD guideline that rules the most part of the world. Now, if you look at the 2018 guideline, remember the first CB outcome trial which came with any anti-diabetic drug to be positive was IMPAREG outcome trial, which was presented at the Stockholm in 2015. Now, in 2018, the ADA-ESD for the first time realized that we need to, stratify our type 2 diabetic patient based on the baseline cardiovascular and renal damage. Still, in 2018, despite those positive outcome data, remember up to 2018, we had positive outcome from IMPAREG, we had positive outcome from CANVAS, we had positive outcome from DECLARE TIMI. All these 3 trial results were out until 2018. And despite all those positive outcome data, the ADA-ESD, although they are stratified for the first time, but then they still put metformin as the first-line drug, regardless of the background cardiorenal status of the patient. However, in 2018, the ADA realized that after metformin, we need to risk stratify, and if someone has got atherosclerotic cardiovascular disease or heart failure or CKD, then they recommended using either an SGLT2 inhibitor or GLP-1 receptor agonist, which shown a positive cardiovascular and renal outcome. However, if you look here, these drugs were only allowed once patients were on metformin and HbA1c target was not achieved. So the ADSD were still conservative despite knowing the positive outcome data from 3 CB outcome trial at that point of time. In 2019, since all these 3 positive outcome trials, then we had results from the DAPA heart failure trial in patients with reduced ejection fraction. Perhaps people realized, those who are sitting in the board of ADA-ESD, in 2019, they become little lenient, but still they put metformin as a first-line drug. But then they suggested that you don't need to look at the HbA1c if patient has got atherosclerotic cardiovascular disease, heart failure, or CKD, regardless of the HbA1c, do select either an SGLT2 or GLP-1 or both if patient has got either ASC, VD, heart failure, or CKD. But still, even in 2019, they put metformin ahead of SGLT2 and GLP-1. Now, if you look 2021 guideline, until 2021, even ADSD, until 2021, we had major, cardiorenal heart failure trials, which, become positive with SGLT2 and GLP-1. Almost all trials, barring, few trials like DELIVER or impaired or reduced, we had all the data in hand. And still, if you look at the 2021 ADA ESD guideline, although they recommended either an SGLT2 or GLP-1 in patients with ASCVD or heart failure or CKD, but still metformin was the first line. So what I'm trying to suggest that despite knowing the positive outcomes from SGLT2 and GLP-1 CB outcome trial, even ADA ESD waited until recently, and I will show you what is the 2022 guideline, and Dr. Hidu has already shown you that data, that, after a wait of almost 7 years, we started thinking a little bit different. However, the ESC were the first people, those who suggested that, well, now we do have data, with SGLT2 and GLP-1 with class 1A evidence, and therefore we would like to bring SGLT2 or GLP-1 up into the algorithm, and you can see the ESC ESD 2020 guideline algorithm recommended that one can use SGLT2 or GLP-1 RA before metformin if patient has got atherosclerotic cardiovascular disease, or they have got a high cardiovascular risk, or if there is history of heart failure and CKD. And this was the first, perhaps, the guideline to come up, upfront to suggest that now we have data with SGLT2 and GLP-1, and this data looks far, far more, comprehensive and, tangential, and therefore put SGLT2 and GLP-1 higher into the hierarchy while treating type 2 diabetes. Now, in 2020, and this is a nice 2022 guideline. So this is a recent guideline from UK NICE. If you look at the NICE UK guideline, they have upfront taken SGLT2. A patient has got even a high cardiovascular risk, as you can see, along with metformin. So, and they suggested that if patient has got high cardiovascular risk, as you can see in your left-hand side, someone having a Q risk score of more than 10% if he is more than 40 years, and if someone who is less than 40 years with type 2 diabetes, with any one or more than one risk factors that includes obesity, smoking, hypertension, dyslipidemia, premature cardiovascular death in family. If you have got a type 2 diabetic patient who is less than even 40 years of age and having any one cardiovascular risk factor, do add SGLT2 along with metformin in even a newly diagnosed type 2 diabetic patient. So therefore, the guidelines in the world tried, trying to implement the evidence which we generated in past decade. And very recently, exactly on 23rd September at this year ESD, as you all know, the latest 2022 ADA ESD position statement and guideline for the first time, suggested that we put metformin little bit into later in the, algorithm, and it's no longer a first-line drug in type 2 diabetes for the first time. So we are nearly 2 months from now that we learned that the ADSD, after a long 7-year wait, come to a conclusion that this is a high time that put the evidence into the clinical practice and put upfront GLP-1 or SGLT2 inhibitor for the patients with type 2 diabetes. If patient has got either a established cardiovascular disease, heart failure or CKD, or even in a patients with type 2 diabetes with high cardiovascular risk. I will come to in detail. So what the current consensus recommendation suggests that if you have got a patients with established cardiovascular disease, a GLP-1 receptor agonist with the positive profile, which has been shown to reduce MACE, or an SGLT2 inhibitor that has shown a reduction in MACE as well as improvement in heart failure and renal outcome, used between any drug. The ADASD also suggested that if you have got a patients with type 2 diabetes, even without established cardiovascular disease, but having a multiple cardiovascular risk factor that includes that if you have got a patients with type 2 diabetes who is more than 45, is obese, having hypertension, smoker, dyslipidemia, albinuria. So even this is risk factors is available, even without any evidence of pre-existing cardiovascular disease or heart failure or kidney disease, prefer GLP-1 or SGLT2. Now, I have put it into different color just to make you understand that if you look both the group, for the GLP-1, this guideline showing the data for only MACE reduction. But for SGLT2, if you closely look and read in between lines for SGLT2, which I colored in purple colored, it is not only the MACE, but is also MACE along with heart failure as well as kidney outcome. So therefore, if anyone is looking even between GLP-1 and SGLT2, of course, for SGLT2, it is 3 landmark parameter, MACE, heart failure, and kidney. But for GLP-1RA, it is only MACE. So there is no debate if I have to choose between GLP-1 or SGLT2. Of course, in patients with type 2 diabetes, I would prefer SGLT2 even before GLP-1RA. Now, Dr. Hideo has shown you this data, and promptly you can see SGLT2 is going ahead in the race. Of course, GLP-1 is there in the ASCVD category, but of course for heart failure and CKD, the SGLT2 should be preferred even over GLP-1RA. And I will come even into detail, deeply dissecting all those data. Now, why SGLT2 should be preferred even over SGLT for GLP-1RA was because of these current recommendations which needs to be implemented in clinical practice. If you look at the latest American Heart Association, American College of Cardiology and Heart Failure Society of America 2022 guideline, for the first time, a SGLT2 inhibitor has been put into a category of class 1 level of A evidence for the primary prevention of heart failure. Now you can see the SGLT2 has got a level of 1A from these associations to be used in patients with type 2 diabetes with either established cardiovascular disease or high cardiovascular risk factor to prevent heart failure hospitalization as a primary prevention. So you have got a class 1A evidence which has been generated for SGLT2 inhibitor. Now, if you look at the patients with heart failure, so in patients with heart failure with reduced ejection fraction, and this we learned through 2 RCT, as you all know, the DAPA-HF as well as IMPERA reduced because of 2 RCT showing a significant reduction in composite of CV death or heart failure hospitalization. The ACC-AHA recommended that there is a class 1A evidence for the SGLT2 inhibitor for the treatment in patients with heart failure with reduced ejection fraction. So you got prevention of heart failure, you got treatment of heart failure with reduced ejection fraction with class 1A evidence. Now, if you look at the patients with heart failure with preserved ejection fraction, at the moment, the AHA-ACC has given SGLT2 a class 2A level of evidence B, as you can see, because when this AHA-ACC guideline was made, we had only results from IMPERA preserved. At that point of time, deliver results were not out, and thus, because only 1 RCT shown positive outcome in patients with heart failure with preserved ejection fraction, at that point of time, the ACC-AHA put them as a class 2A. But we believe that in the future, looking at the deliver data as well, because there are 2 RCT which has shown a similar significant positive outcome in patients with heart failure with preserved ejection fraction, we expect that the next AHA-ACC guideline should put even SGLT2 as a class 1A, or at least, to a grade A evidence for the SGLT2 based on this 2 RCT, IMPERA preserved and delivered trial. So ladies and gentlemen, if you look at the current scenario of SGLT2 in terms of heart failure, we have got a prevention for 1A evidence, we have got reduction for reduced ejection fraction 1A, we have got SGLT2 for preserved ejection fraction at least 2A, and we expect to be even class 1A once deliver result is taken into account. Now, Dr. Hido talked about kidney. So let's shift little focus to kidney. So this is the current KDIGO 2022 guideline. And Dr. Hido has suggested that at the moment, basically, you are compelled to use a SGLT2 inhibitor in patients with CKD, even if you have got a patients with type 2 diabetes with CKD defined as EGFR less than 60 or albuminuria more than 30 microgram per gram, you must use a SGLT2 inhibitor for the treatment of diabetes to prevent the progression of chronic kidney disease. So the current cutoff is that if you have got a patient with CKD and if the EGFR is more than 20, you must use a SGLT2 inhibitor to prevent progression of ESKD, renal transplantation, or doubling of creatinine. And one should not stop even the SGLT2 inhibitor continuation, even if the EGFR falls below 20 ml per minute, unless it is not tolerated or patient is requiring kidney replacement therapy. So this is the current KDIGO guideline recommending highly to use SGLT2 inhibitor in every patient with CKD as long as EGFR is more than 20. If you look at the EMA and FDA level update, so I have just updated the latest level update for SGLT2 and GLP-1 RA in the next slide. If you look the level update of a different SGLT2 inhibitor, you can see at the moment IMPA has got the level update of CV death reduction based on IMPA reg outcome trial. We have got IMPA for the reduced ejection fraction. We have got IMPA for preserved ejection fraction, and very recently we had positive outcome data from the IMPA kidney, and we expect that in sooner or later even empagliflozin should have a level update for patients with diabetic as well as non-diabetic CKD, as it has been given for dapagliflozin, as we saw in the DAPA CKD trial. Now, the CANA has got, for the diabetic CKD based on the credence. The CANA also has got 3 PMS based on the CANVAS program. Dapagliflozin has pretty similar level update like empagliflozin. And as you all know, yesterday, the EMA has given level update for dapagliflozin in patients with heart failure, regardless of diabetes or, CKD, diabetic CKD. So at the moment, dapagliflozin has got level update for non-diabetic CKD, as well as patients with heart failure, regardless of ejection fraction. So thus, we now have data for prevention for dapagliflozin. We have got data for prevention for the treatment for reduced ejection fraction, for the treatment of preserved ejection fraction, as well as patients with kidney disease. It includes both diabetic as well as non-diabetic CKD. Now, if you look at the GLP-1 receptor agonist basket, and why I'm showing you these data, that they also have got several level update. But if you count the number of green tick colored, which I've shown you previously, of course, the GLP-1 does have several green tick, but then it is, if you look at the compare at the GLT2 versus GLP-1, the GLT2 has far larger number of green ticks, especially in patients with heart failure and kidney disease. The GLP-1 RA renal outcome trials are currently under progress. If these trials becomes positive in their dedicated renal outcome trial, maybe in future, we might find GLP-1 RA also at upfront, for the treatment of diabetic kidney disease. But at the moment, we don't have similar robust data in terms of kidney protection for GLP-1 RA as we have for the SGLT2 inhibitor. Now, so if you collectively look at the evidence which has been generated in past decade, this is the latest editorial we wrote in the last issue of Clinical Diabetology, and we tried to understand GLP-1 versus GLP-1 RA in terms of data we generated. If you look at the SGLT2 inhibitor, we have a confirmed data in patients with type 2 diabetes. We have shown you all those data. We have confirmed data in patients with CKD, regardless of diabetic kidney disease. in the form of DAPA-CKD and now IMPA kidney as well. We do have data in patients with heart failure with reduced ejection fraction in the form of DAPA heart failure and impairer reduced. We do have positive outcome data in patients with heart failure with preserved ejection fraction, as we learned from the DELIVER as well as impairer preserved. Now, we also have almost confirmed data with SGLT2 in patients with acute heart failure. Remember, in the Soloist heart failure trial, SGLT2 was initiated even during the hospital, the moment, the heart failure was stabilized. And within 3 days of discharge, the sotagliflozin was used. We do have no data from acute heart failure trial like IMPA response heart failure, as well as IMPULSE trial. Those were decompensated acute heart failure, and yet SGLT2 inhibitor shown positive outcome. So therefore, the SGLT2 inhibitor is also entering into segment of acute heart failure, not only chronic heart failure, but into acute heart failure. The SGLT2 is also entering into the space of MI. We do have some data from trials conducted in patients with acute myocardial infarction, and those data are positive. We are waiting for the last trial like IMPACT MI and DAPA MI so that we conclude that SGLT2 really work to improve cardiovascular outcome in patients with acute MI. But at least 2 trials at the moment, although a smaller scale trial in patients with acute MI, did find a positive outcome with SGLT2 inhibitor in patients with acute MI. There are a number of trials at the moment going in patients with non-alcoholic fatty liver disease, polycystic ovarian syndrome, etc., and we are waiting for those data to come with SGLT2 inhibitor. On the other hand, if you look at the GLP-1 data, of course, GLP-1 also shown a positive cardiovascular outcome, especially in reduction of atherosclerotic cardiovascular endpoint in several trials like LEADER, as well as in REWIND. But then at the moment, data of GLP-1 is restricted to type 2 diabetes, and we don't have data in patients with heart failure or in patients with CKD. Some data suggesting the GLP-1 could be a good agent for NAFLD or PCOS, but these data needs yet to be explored, especially in patients with heart failure or MI settings, or in patients with atrial fibrillation. We do have some data with SGLT2 to reduce atrial fibrillation, but then there are RCT right now going on with SGLT2 for atrial fibrillation outcome, and we are waiting for those data. So what I'm trying to suggest that, of course, both the drug has got great data, but SGLT2 somehow looks to be, moving ahead compared to GLP-1 on a broader segment of type 2 diabetes, including heart failure as well as CKD. Now, if you closely look at those data, so little busy slide. So if you look at different endpoint for the MACE, we have got similar data. If you like, these are the latest data which we pulled into this forest plot from the largest meta-analysis of GLP-1 cardiorenal outcome trial and SGLT2 cardiorenal outcome trials. What we could generate that when it comes to MACE reduction, perhaps GLP-1 and SGLT2 is similar. When it comes to MI, maybe SGLT2 and GLP-1 could be similar, and some data suggests that SGLT2 could be even superior to GLP. Remember, these are not head-to-head trial between 2 class of agent. Rather, these are indirect evidence to understand whether benefit on cardiorenal endpoint is similar or not. Now, if you look at the stroke, of course, GLP-1 data is far, far better than SGLT2. When it comes to mortality reduction, CV death and all-cause death data at the moment between GLP-1 and SGLT2 looks to be similar. For the heart failure, SGLT2 is far ahead. We don't have any positive heart failure trials of the GLP-1 at the moment. And similarly, for the renal outcome data, the SGLT2 seems to have the best bet compared to even GLP-1. So therefore, if you look at the 3 endpoint, atherosclerotic cardiovascular endpoint, vis-a-vis heart failure, vis-a-vis renal outcome, it looks like that GLP-1, not only in terms of comfort of being an oral drug or much cheaper than GLP-1, but also in terms of cardiorenal outcome seems to be ahead over GLP-1 RA. Now, therefore, ladies and gentlemen, to implement these outcomes and the implement algorithm from the different CV renal outcome trial, what we have learned so far. So how to treat diabetes in 2023, knowing all these guidelines in the world, which has been published till date. Now, one thing is pretty clear, which I learned, that when you are treating type 2 diabetes, when a patient with type 2 DM comes into your clinic and sitting in front of you, ask first question: has the patient risk factors for cardiovascular disease, or has the patient established cardiovascular disease, heart failure, or CKD? Now, when it comes to risk factor, you can see here, those are the risk factor. The NICE 2022 suggests that even if you have got one or more risk factor, you are eligible for a SGLT2 or GLP-1. The ADA ESD suggests multiple. Multiple, the sub is little vague. There is no clarity. What do you mean by multiple? More than 2 or equal to 2 or 5 or 3, clearly suggesting that if you have got a high cardiovascular risk factors, where the patient has got obesity or smoking, dyslipidemia, hypertension, albuminuria, if the patient is more than 55 years, use SGLT2 or GLP, regardless of age, regardless of BMI, or regardless of background therapy. Please read in between the word, suggesting that regardless of age, so you don't deny benefit of these class of drug if you feel that someone is sitting in front of you who is elderly. I will show you those data. We are very much reluctant to use these drugs, especially in elderly. And also, regardless of BMI, sometimes you feel that, oh, this patient is not obese, so therefore I would not prefer GLP-1 or SGLT2. This should not be, the factor of deciding using SGLT2 or GLP-1 if the patient has got high cardiovascular risk or has got established cardiovascular disease or heart failure or CKD. If the patient doesn't have cardiovascular risk factor, then you have got a cafeteria choice. But then look into the BMI into the picture, and this is what ADASD 22 guidelines suggest. If you have got an overweight or obese patient, prefer SGLT2 and GLP-1 RA over any other anti-diabetic. If you have got a patient without any risk factors, even a single, or without established heart disease or heart failure or CKD, then you have got a cafeteria choice to choose from any class of drug. If you further dissect this data into detail in the cardiovascular disease, so let's divide what kind of cardiovascular disease. If the patient has got ischemic heart disease, you can choose further between SGLT2 or GLP-1. There is no great choice. Of course, patient comfort, cost, everything has to be taken into account. But from the data perspective, for the ischemic heart disease, both SGLT2 and GLP-1 has got similar data. For the stroke, of course, I would prefer GLP-1 RA over SGLT2. And the current ADA ESD guideline, what I noticed, has brought back pioglitazone into picture and have put pioglitazone much higher in the hierarchy if patient has got a stroke. And I'm sure this must have based on both proactive as well as IRIS trial. They have found pioglitazone to have some edge in preventing a stroke in patients with insulin resistance or IGT or past history of a stroke. And therefore, the GLP-1 or pioglitazone should be the preferred agent in patients with a stroke. For the peripheral vascular disease, of course, I'm going to prefer GLP-1 over SGLT2 because of some hint of increase in amputation, as we learned in the CANVAS program, although it wasn't replicated in the CREDENCE trial. Now, when it comes to the other cardiovascular risk factors, like whether you are looking into heart failure, SGLT2 is the first choice. The metformin should be preferred over GLP-1 for the heart failure patient. At the moment, ADASD suggests you can choose between GLP-1 RA or metformin after SGLT2. And then, DPP-4, in DPP-4, only sitagliptin or linagliptin. Or fourth choice would be sulfonylurea, because we learned in the Carolina trial that glimepiride did not increase heart failure compared to linagliptin, but no pioglitazone in patients with heart. Now, when it comes to CKD, and this is a very latest paper we wrote, this is ahead of print issue, we wrote for diabetic kidney disease. I'm sure Professor Hideo would agree with me. We had too much difficulty while answering the reviewer for this particular paper, because if you look here, we were a little bit upfront to suggest that if you have got a diabetic CKD, of course, you start with a RAS blocker, go to maximize the dose of RAS blocker, and then ask a question: are SGLT2 inhibitor contraindicated or not tolerated? If answer is no, then prefer SGLT2 inhibitor. If answer is yes, means SGLT2 is not tolerated or contraindicated, then finerenone, if the patient has got required eGFR of more than 25 mils per minute, and if patient has got a CKD, and if a patient has got a serum potassium less than 5 milliequivalent per liter. If you look at the ADA ESG guideline, they also suggested that consider GLP-1 RA therapy if your patient has got a priority to reduce blood glucose, or HbA1c target is not achieved after SGLT2, the GLP-1 may be preferred. And they did not mention, whether GLP-1 should be preferred over finerenone. So these areas are a little bit gray, but then we think that still, if you look at the data in patients with DKD, after the RAS blocker, we would prefer SGLT2 over finerenone for several reasons, which we put forward in this paper, why SGLT2 should be put, above finerenone. Yes, well, and he can use a combination of the drug, but then if I have to choose between SGLT2 and finerenone, I would prefer using SGLT2 prior to finerenone. Simple reason, not from the cardiorenal endpoint, superiority, but from the comfort that using SGLT2, as Dr. Hideo talked just now, it will enable more patients to continue with the finerenone, because SGLT2 will prevent hyperkalemia induced with the finerenone. Remember, the only drawback of finerenone is the hyperkalemia. Of course, even with finerenone, the hyperkalemia was much lesser than the previous steroidal MRA like the spironolactone or eplerenone, but compared to placebo, even finerenone causes higher hyperkalemia compared to placebo. And therefore, we need a drug that can beforehand reduce hyperkalemia, allowing more patients to continue with the finerenone. And finally, before I conclude, let me I would like to tell you that the two populations where perhaps physicians are very much reluctant to use SGLT2 inhibitor are elderly and frail. Remember, if you look at the SGLT2 trials, both reduced ejection fraction and preserved ejection fraction trial, if you look at the elderly population, you would be amazed to believe that 80% of patients as high as in the Emperor preserved were elderly population. And yet, the benefit of empagliflozin or dapagliflozin in DELIVER trial was clearly there in people, those who were elderly. So therefore, as I have shown you, regardless of the age or even BMI, if the patient has got established heart disease, heart failure, or CKD, please don't hesitate to use these class of drugs. And finally, I will take you quickly to two slides. If you look at the recent paper by Professor Braunwald, he went in to suggest that the SGLT2 inhibitor is a new statin. And I will rather provoke you, could it be better than a statin? And I'm sure Dr. Hideo is going to ask me and drag me on this issue. So if you look at this editorial, Braunwald Corner in European Society, European Heart Journal, he put forward that SGLT2 is the statins of 21st century based on those trials. Now, what I'm trying to go even beyond what Professor Braunwald suggests, if you look at the data, the SGLT2 inhibitor deserve to take first place in the treatment of type 2 diabetes, in particular from the Indian perspective, because at the moment, a tablet of SGLT2 inhibitor is less than 10 cents in India compared to United States. If you look at the data of SGLT2 versus statin in patients with CKD, and in particular in patients with heart failure, I still feel that the SGLT2 has far more robust data compared to a statin in patients with CKD and heart failure. And I will show you those events. Now, it comes to the SGLT2 versus statin, I do believe that the SGLT2 inhibitor seems to have better data than statin, even in terms of reducing the heart failure as well as protecting kidney. And look at this slide. I just did a systematic review and look at those data of statin patients with CKD. The data are inconsistent for a statin in CKD, unlike the SGLT2 inhibitor. Now, if you look at the heart failure data for the statin, unfortunately, none of the statin data were found to be positive in patients with heart failure. Look at this two study, Corona and GC heart failure trial, both failed to show any positive CV outcome in patients with heart failure. And therefore, I would put forward that if you have got a patients with heart failure and CKD, perhaps to me, data for SGLT2 is even better than statin. So, ladies and gentlemen, to finish my presentation, what I learned, at the end of 2022, looking at the data for past 10 years, which we generated so far, the treatment of type 2 diabetes is no longer glucose-centric. We have to think about disease, and perhaps further modifying the outcome approach should be the ultimate path. It's not only the glucose control or even disease-centric control, but we need to finally cut down the complications of diabetes. The preventing cardiorenal disease is the doctor's final goal, and therefore choosing a pharmacological agent to prevent cardiorenal disease should be first priority. Now, from the Indian perspective, why we are really enthusiastic. If you look at the cost, although ADA ESD waited for 7 years to put SGLT2 or GLP-1 RA above metformin, but we feel that we don't have any debate here. When it is a cost effectiveness, if you look at the cost, if you look at the innovator dapagliflozin in the India for SIGA, that costs 27 Indian rupees, which is basically 10 cents of USA. If you look at the branded generic at the moment in India, this may cost somewhere between 10 to 15 Indian rupee. Versus if you look at one tablet of Farxiga in United States, it is $18 US. That translates into nearly 1,500 Indian rupees versus a 15 rupees dapagliflozin with a branded generic. 15 rupees versus 1,500 rupees in terms of United States, conversion money. We have got such a cheap drug at the moment in this country. Why not implement into the clinical practice when it comes to cost effectiveness of the drug and the cardiorenal positive outcome data from those trials? I believe with this knowledge from Professor Hiddo and what I put you the perspective for SGLT2 vis-a-vis GLP-1 and the evidence, I'm sure we are going to implement these drugs into clinical practice sooner. The sooner, the better. Thank you very much for your patience listening.
Thank you, sir. Due to lack of time, we will take a few questions only. So first question is, when to start SGLT2 inhibitor in CKD patients? At what stage of CKD? Or can we start the gliflozin in new type 2 diabetes mellitus patient to avoid the kidney damage?
Let Professor Hiddo answer it.
Let me take this question. I think it's very important that we should not only consider the kidney, we also have to realize that these drugs are heart failure protective, cardiovascular protective, as demonstrated by Dr. Singh. So we can even initiate them if there is no kidney disease present, because you can still reduce heart failure, cardiovascular disease. In other words, as nicely illustrated by Dr. Singh, these drugs are effective across a broad range of patients, early, no kidney disease, early or established kidney disease. And if you have established kidney disease, your absolute benefit will be greater. But don't forget that there's much more than the kidney. These drugs are cardiorenal protective.
Okay, sir. Thank you. Another question is, sir, please give opinion on usage of gliflozin 1 in pre-diabetes and pre-hypertensive patient in Indian setting. What would be the dosage in pre-diabetes?
Well, Dr. Singh, you can take this one.
Yeah. So at the moment, we are not licensed to use SGLT2 inhibitor in pre-diabetes, and therefore no question of dosing comes into the picture. We don't have enough data at the moment that suggests that we can use SGLT2 inhibitor in patients with pre-diabetes. So this question is actually not valid. We have to generate data. We have to have a license for the SGLT2 in pre-diabetes. But then, having said so, if you look back at the the data which we generated from DAPA heart failure or from Deliver, as well as from Impera reduced and preserve, in these trials, patients having IGT, the SGLT2 inhibitor, were able to reduce progression from IGT to frank diabetes. Remember, in DAPA CKD, if I remember correctly, there were 32% reduction in progression from IGT to frank type 2 diabetes. And if you meta-analyze those data, I remember this data comes to 38% reduction, 38% in DAPA CKD, and combined DAPA CKD and heart failure, it was 32% reduction in new onset diabetes, progression from impaired glucose tolerance. So data looks to be, good in patients with IGT as well as heart failure or CKD. But at the moment, we don't have license to use SGLT2 in patients with pre-diabetes. Dr. Hido,
one short addition. In patients with chronic kidney disease or heart failure who do not have diabetes, many of them will have pre-diabetes. And in these patients, SGLT2 inhibitors reduce the onset of type 2 diabetes and reduce the risk of heart failure and kidney failure. So although indeed from an endocrinology perspective, if there's no kidney failure or kidney disease or heart disease, you cannot use them. But we know they are effective if based on the trials, as just mentioned.
Yes. Or in other words, if you have got a patient with CKD or heart failure, then you are licensed to use even if there is a pre-diabetes. So for patients with CKD and heart failure, you don't need to look at the HbA1c. Regardless of diabetes, you are licensed to use SGLT2 inhibitor.
Yeah.
Okay, sir, one more question. In which patients we should avoid the usage of SGLT2 inhibitors?
Sorry, we could not get it. Please repeat.
In which patients we should avoid the usage of SGLT2 inhibitors?
We should avoid. Right. So let Professor Hido speak on that. I will.
Yeah. So you should not initiate an SGLT2 inhibitor in patients with type 1 diabetes. Because of the risk of ketoacidosis. In a patient with recurrent urinary or genital tract infections, I would be careful. I would not definitely exclude it, but I would be careful and I would explain and give proper instructions to the patient to avoid genital and urinary tract infections. Hygiene is most important. In a patient with a high dose of diuretics and a dynamic circulating volume, for example, an elderly patient, I would give clear instructions what to do and to avoid volume depletion, orthostatic hypotension, and potential falls that can lead to fractures. One of them, reduce the background hydrochlorothiazide, half the dose, in order to accommodate the SGLT2 inhibitor. In patients, there has been a lot of discussion whether we should initiate these drugs in patients with peripheral vascular disease, and I don't see any reason why not to initiate them. So you can initiate them. So overall, there's a broad range of patients in whom you can initiate an SGLT2 inhibitor. And perhaps Dr. Singh can add something if he wants.
Yeah, I fully agree with you. I have got one question to Dr. Hido. This is my personal question to know about progress of SGLT2 in field of non-diabetic CKD. So although we are licensed to use SGLT2 inhibitor in patients with CKD, regardless of type 2 diabetes or whether it's a CKD due to diabetes or whatever may be the cause, regardless of the etiopathogenesis of CKD. So I do believe that if you have got a patient with CKD because of chronic glomerulonephritis, you are licensed to use SGLT2. However, if we go back to the the DAPA-CKD as well as IMPA kidney outcome trial, we did not assess SGLT2 in patients with polycystic kidney disease as well as the kidney disease due to collagen vascular disease. So what is the status of SGLT2 in lupus nephritis, or means the CKD due to lupus nephritis, or CKD due to PSCKD, polycystic kidney disease?
So we can only initiate these drugs in the patients in whom we have proven the efficacy and safety of these agents, right? We have not studied them, so we cannot use these drugs in these patients. That's a very simple answer. The more complicated answer is, are we going to generate the evidence, and are we going to demonstrate that SGLT2 inhibitors is going to be protected? We have started a clinical trial in the Netherlands and Germany and Australia in 1,500 patients to generate the evidence that in people with very late stage of CKD, dialysis, transplant, and patients with a GFR below 20, including ADPKD patients, SGLT2 inhibitors are going to be effective. That's a big trial. Will take a couple of years. We're testing dapagliflozin, and I hope to come back to you in a couple of years with the results of that clinical trial.
Okay. So, moment.
Thank you very much. I think we are over time, so I think we should let the audience take their evening rest, but I'll give it back to the chairman.
Thank you, sir. Thank you so much for the informative session and the wonderful session, both of you, Professor Hido and Dr. Avdesh, sir. So we would love to have such interaction in the future as well. And thank you for the informative session, sir. Such a beautiful session. Thanks a lot.
Thank you.
And thanks to the audience as well for listening.
Yeah, thank you. It was a pleasure.
Bye-bye.
See you soon. Yeah.
See you soon. Have a nice holiday season.
Same to you.
Thank you.
Yeah.
Thank you, everyone.
Thank you.
Yes, thank you, sir. Thank you. Yes, sure.
Hello.